Hello, everybody, and welcome, and thank you again for joining us today for our Empowering MBC webinar. My name is Lauren Jost, and I'm the project coordinator for the Breast Cancer Engagement Group, as well as the Breast Cancer Program here at Washington University in St. Louis. And we're so glad that you could be here. And we truly appreciate your time and dedication to supporting and uplifting the voices of those who have MBC. I do have a few announcements today, if my slides would pass. There we are. We have our our next support group for or titled Living Empowered MBC Support is going to take place Wednesday, September 24th with Lauren Balmer, our WashU Living Well Center's athletic trainer, will be joining us to help us incorporate physical activity into our daily lives, as well as show us a few different stretching exercises we can use with ThoroBands. So that should be fun. If you're interested in joining and you're in the St. Louis area, feel free to register. We also do have a virtual option. So if you have a ThoroBand at home and you want to join via Zoom, feel free to also register and we can get that link to you. And then we have our next. We're also excited to share our upcoming webinars, which are taking place both in October as well as December. So in October, we'll be welcoming our local and national patient advocates, caregivers, as well as anyone who will be in attendance to discuss their experiences with MBC. And with it being Breast Cancer Awareness Month in October, we wanted to put forth MBC awareness as well. And then in December, we are having Dr. Cynthia Ma and Dr. Nusaiba Bajegni join us for MBC trials. And that's going to be following our San Antonio breast cancer symposium. And so we're hoping to get some new insights on some MBC trials. And we'd love for you to join us and see what we learn. It'll be a good time. Let's see. And don't worry, with all the QR codes I'm putting up on the screen, I will make sure to send them out also in the newsletter. Follow emails. We'll have the direct links as well. So that will help. And I'm sorry, I'm looking away. I'm also continuing to admit individuals as well. Okay, then our next slide. We finally have it, my friends. Our new webpage is launched with our through Siteman, and thank you to the Siteman development team for helping us make this webpage. It's going to be our new MBC hub for WashU and Siteman. We have our support group information there. We also have our webinar information. We're hoping to have a resources page complete with links to different local and national resources, as well as a trials tab at some point. So continue to look for that. And I will put in all these links again in the chat as well as follow-up emails. And then today we are honored to welcome our featured speaker, Dr. Katherine Weilbaecher, the Oliver M. Langenberg Distinguished Professor of Science and Practice of Medicine at Washington University. She'll be sharing her expertise on breast cancer bone metastases. And then following Dr. Weilbaecher's presentation, we will be moving into a town hall discussion, which will be guided by Josh Newby, the founder and executive director of Teresa's Research. This will be an opportunity for an open conversation, questions related to today's topics, which you can put in the chat and we will make sure to read, or if you're interested in reading them yourself, feel free. And then we will also share experiences if you're interested. As a reminder, the information shared here is not meant to be a diagnosis, treat, or replace professional medical advice. We strongly encourage individuals to consult with their medical providers for personalized medical guidance, diagnosis, and treatment options. And as a note for today's webinar, it is being recorded, which you probably all have seen in a pop-up on your screen, but I will stop the recording once we get to the town hall, and we will make sure to keep that private. Additionally, a short anonymous Zoom survey will pop up on your screen once we conclude today's webinar. If you can take maybe the 2 minutes it takes to fill it out, we'd happily appreciate your feedback, because the more we can get, the better these webinars will be. And then last but not least, again, my name is Lauren. I am the central contact for the Empowering MBC Voices as well as the support group. So if you have any questions, feel free to email me at the empoweringmbc@wustl.edu email address. And without further ado, I'm going to pass things off to Dr. Weilbaecher. And thank you again for coming.
Okay. Let me share my screen. And okay, hello everyone. Lauren, can you see the screen?
Yes, ma'am.
And you can hear me?
Yep.
Okay, hi. Um, Lauren, I am so impressed. This is a really exciting program. We have to spread the word. Oops, excuse me. Thank you, everyone. And so I am a medical oncologist. I focus on breast cancer, but my research, my preclinical research and clinical research focuses on how can we bone metastasis, what are they and how can we stop them? And let's see if we can get to, okay. What I'd like to do in this talk, and then hopefully in the question and answer, if you have questions for me, I want to go over bone metastases. How common are they and what are they? How do tumor cells change the normal bone cells, co-opt them to cause problems? And what are some of the benefits of strengthening our bones and targeting our bones, not only to prevent problems, but to actually fight cancer? And then a few ideas of either from my own lab and other ideas of what's next. And I just want to take a shout out to some of my many patient teachers who have taught me about bone metastases, what they really are. They're just one small part of the journey. They're not who we are, and who have been my life teachers. Um, so, bone metastasis. What sometimes some of my patients will say, do I have bone cancer? And so I just want to give a few definitions. So a bone metastasis is when breast cancer cells land in the bone marrow. So they get into the circulation, land in the bone marrow, which is at the center of the bones, and they grow and then they invade and break down the bone. What a bone marrow metastasis is when the breast cancer cells land in the bone marrow. Sometimes they can just go dormant, or sometimes they can grow in the marrow space, but they don't invade. And then the bone cancer is a cancer that arises from bone cells like osteoblasts or fibroblasts. So a bone cancer is like a primary bone cancer, like an osteosarcoma. So when we say a bone metastasis, that's a breast cancer cell that got into the bone. Um, and so bone is the most common site of breast cancer metastasis. It's the most common. Then you might have lung or adrenals, liver, skin, but 4+ for bone, it's the most common site of metastasis, and we have a lot of treatments for it, thankfully. The ER positive breast cancer is the most common type of breast cancer that will get bone metastasis. So 72% of patients who have metastatic cancer that are ER positive will have a bone metastasis. But HER2 amplified patients and triple negative patients also are at high risk of having a bone metastasis. So just a very big schema of how metastasis happen and how I think about it. Let's say the purple cells are your breast cancer tumors, and they can recruit blood vessels that then can um, give these tumor cells an ability to get into the bloodstream. Thankfully, most tumor cells die in the bloodstream, either immune attack or they're not getting the nutrients. However, some of the cancer cells can get into, in this case, a bone, and get into the bone marrow. Most of the time, the cells die, but some of the times they can take root. And what this is an X-ray, actually a CAT scan of a pelvic bone. And this is the back of the body. These are the intestines. This is the pelvis. And you can see these sort of white calcified little tumors. And some of the tumors are causing holes in the bone. Some of them are causing the bone to build up. And these would be a bone metastasis. They've kind of entered into the bone. And so bone metastases, there are many ways that we can find them, detect them. And this is an FDG PET CT scan. Some of you get PET CTs. And this is the side profile. This is the spine. And you can see where there's glucose uptake in a PET scan. Those might be spots where a bone metastasis is. This is a bone scan, which is actually, it doesn't show the tumor, it shows the bone's reaction to having a tumor. And again, you can see all these white spots. Now, because the bone marrow is liquid and all the bones are contiguous, we often do see a lot of spots in the bone. It doesn't necessarily mean like, oh my gosh, this is terrible. It's sort of the nature of bone metastasis. We often have a bunch of them. Now, sometimes that bone, and you're going to learn a lot about bones today, the tumor could get into a spot of the bone and begin weakening the bone, and you're going to learn about that, and that could cause a fracture. And this, we would call this pathologic fracture. And so when the tumors get in the bone, thankfully, most patients don't have many problems from the bone metastases. But if untreated, about half of the patients, half people will have problems such as pretty significant pain. Sometimes they can induce a fracture. Sometimes the tumor cells can cause the osteoclast to release a lot of calcium in the blood, and that can make you sleepy and it can cause problems. We really want to know about that. And sometimes if the tumor gets near the spinal cord, that can be a problem. So we want to, how can we treat these? And so let's first try to understand a little better what they are. So over 100 years ago, Dr. Stephen Paget, he was a breast surgeon in London, he made the observation that patients, women with breast cancer, have a predisposition to have bone tumors spread to the bone compared to any other site. And he said there must be something about the tumor cell, which is the seed, and something about the bone, which is the soil, that attract each other. And he made this hypothesis of the seed and soil, that we need to study both as doctors and scientists. And I've been thinking about this for the last 35 years. And just as an example, this soil, gives the nutrients and the support. And if you can, the long story short, if we can strengthen that soil, the cancer cells don't grow very well. And in fact, if we give bone strengthening agents, agents that don't directly kill the cancer cell, we can stop those skeletal complications of pain, fracture, spinal cord compression by up to a half. So we really do need to study the bone and the bone cells. So here we're jumping into, let me look at the time. Okay, we're jumping right into our biology lesson, and you're going to be experts on bone by the end. So bone, this is a sort of a cartoon of bone. These little green cells are what we call osteoblasts. These are the cells that line the bone surface and they lay down bone. They make collagen. So collagen is not only in the skin, it's also in the bone. They lay down collagen and they mineralize the collagen to create this hard bone. But these osteoblasts also can regulate these osteoclasts. Osteo means bone. Osteoclasts are sort of like the white blood cells of bone. They come from our immune system, hematopoietic system. They're like macrophages, but they get onto bone. These little blobs in the middle, they fuse together and they have these multinucleated cells. They, what we call, ruffle their border, and they secrete acid and collagenases. Acid is going to dissolve the calcium, and collagenases is going to dissolve the collagen, and they destroy old bone. And this process is highly regulated. Every 10 years, our skeleton is completely turned over. We have completely new bone because the old bone gets eaten up and then the osteoblasts lay down the new bone. Okay. So this is a normal process. And just to demonstrate, Lauren Jost, who's been our leader of the MBC program forever, I told her about, I wanted to give a demonstration of just how important acid is, because it turns out, let me just back up because it's so, whoops, I don't know if I can back up. It turns out that these that when cancer cells get in there, they can get rid of collagen, but they cannot demineralize the bone. The cancer cells enslave the osteoclast to make the acid to destroy the bone. And that's what we're going to try to block with our drugs, Zometa and Xgeva. So cancer cells cannot do the osteoclast job. And so we've got to deal with this. So this is just an example of Lauren's adorable kids. We put a leg bone of a chicken leg in water and in vinegar, which is the acid. And after a few days, we could see an acid that is one bone that's being bent like rubber. All of the calcium leaves that bone, and you can now bend the bone. Thank you, Lauren, for the experiment. So, what do we know about bone? We want to keep them strong, and we want to prevent that weakness. And so we know that weight-bearing exercise really stimulates osteoblasts and it inhibits the osteoclast. So that's very good. But we also know that estrogen really maintains our bones. And estrogens can stimulate the blasts and inhibit the class. When we block estrogens, especially for our ER-positive breast cancer treatment, we actually can accelerate osteoclast formation and destruction of bone. So not only is that not good for our bone strength, but I'm going to tell you in a minute that actually can help the cancer a little bit. So we need to make sure if we're blocking estrogen that we got to keep our bone strong too. So now we're going to move into the cancer part. So what we've learned is when these seeds or the cancer cells get into the bone, as I said, they get in that bloodstream, they get into the bone marrow. Most of the cells die, but some of them, they can secrete proteins that basically start causing these osteoclasts to grow and develop. And what we found out through many studies is that within the bone, in that mineralized bone, when the osteoclasts chew up the bone, they release growth factors that help the cancer cells grow. So you get this sort of vicious cycle. The cancer cells make the osteoclast acting factors, the osteoclasts release some growth factors, and we get this sort of vicious cycle. Obviously, our most important task as oncologists is to try to stop the cancers from growing. But we have to also remember, we also need to not neglect the actual bone cells that are part of this process. So basically what we've shown and others is that when breast cancer grows in the bone, it can stimulate this bone destruction. That can sort of help it grow a little bit. And so we can block, if we strengthen the bones and block the osteoclast, we stop feeding the cancer. And if we block the breast cancer, we stop hurting the bones. So strengthening the bones is key. And so now and I know this is a lot of information. I'm going to switch into the therapies and the new horizons, but I'm happy to talk about anything about this. So for bone metastases, of course, we want to give systemic anti-cancer therapy because the bone marrow and the bones are all connected. And so that's a big focus. But we also, if you do have cancer cells that have spread to the bone, we need to make sure we do that bone strengthening therapy, which I'll tell you about, which is either the most common are Zometa or Xgeva or denosumab. And then we also have local therapies. Let's say you have a spot that we're worried about, that it's the bone is weak, we might, or it's hurting, we might give a little radiation therapy. Sometimes we need to repair the bones with surgery. And then I'll tell you about, we can inject cement in the bones too. Um, but I'm going to talk to you guys a little bit later and make a plea for weight-bearing exercise and mechanical loading when it's safe, and we could talk about that, and vitamin D and calcium. One thing that I didn't, I'm going to go back. I'm sorry, guys, I'm going back and forth here, but let's go to this slide while I can. So, calcium and vitamin D and weight-bearing exercise. I'm just going to cut to the chase. Osteoblasts, those are those bone building cells. When you walk or weight bear, okay, not swimming, although swimming is good for muscles, but when you put pressure on bone, that stimulates the osteoblasts to make more bone. And astronauts, when they're in space in zero gravity, they become osteoporotic. They lose so much bone because we need to keep some pressure on the bone to keep it growing. Vitamin D helps put calcium into bone. The osteoblasts need the calcium to put it into bone, and vitamin D tells the osteoblasts, stick it into the bone. When calcium is low, the body says, okay, osteoclasts, we need more calcium, chew up the bone. So that's why we want to keep our vitamin D levels good, and we want to make sure we have enough calcium. And it's hard to get calcium unless you're avid milk drinkers. And so that's why sometimes we have to supplement. Okay, moving forward. Anti-bone resorption therapy. Those are the bone strengthening therapies, osteoclast inhibitors. So I've told you, osteoclasts, those are the cells that secrete the acid or the vinegar to destroy the bone, and that weakens the bone and causes pain and problems. These agents are used in osteoporosis. So this is an electron micrograph of an osteoclast, and this is a piece of bone. And that one cell just sweeps along the bone, degrading it. I mean, that one little cell is impressive. So we have these drugs called bisphosphonates. And some of you might have heard of Fosamax, but many of you who have bone metastases may be on Zometa. This is a type of bisphosphonate, and it lays down into the bone surface. And when the osteoclast gets on top of it, it can't work. So we like these drugs. And this is a study that was done where patients with breast cancer that had bone metastasis were randomized to receive placebo or Zometa. And the yellow is the number of patients that had a skeletal related event, such as need for radiation, fracture, spinal cord compression, or hypercalcemia. Those are the women that got placebo. The patients that got Zometa had nearly cut in half the need for radiation, by a third the fractures, more than half for spinal cord compression. This was a huge thing. What's not written on here is the pain, the bone pain and need for pain medicines was cut more than half. This now has become standard of care. So then another drug came along called denosumab or Xgeva, and in the osteoporosis setting, we call it Prolia. These are neutralizing antibodies to rank ligand. Rank ligand is the food for osteoclasts. Erythropoietin makes red cells, rank ligand makes osteoclasts. So if you block this, you don't get osteoclasts. It can be given subcutaneously. Zometa is IV. It's slightly more effective in Zometa in decreasing these skeletal complications, but there was no difference in outcome or overall survival. But the challenge of Xgeva is we cannot stop this cold turkey because the body gets used to this blockade. And when you stop it, the body starts making osteoclasts like crazy, and you start breaking down the bone that you just built up. So we can, that's just something before you stop it, you got to talk to your doctor. And so how do we dose it in the metastatic setting? If you have active bone metastases, we give it every 3 to 4 weeks. But if the treatment is working and things are stable, we can start decreasing the amount. Like we might give it every 3 months. We might then start every 6 months. And, we have patients who are on some of our treatments for years, the anti-cancer treatments. And if the disease is under control, we can maybe give it less. For Xgeva, you have to at least give it every 6 months. We can't go longer like we could with Zometa. But we could give Zometa and transition if needed. So this is what we see. Just for those of you that might be starting Zometa, the first dose can be a doozy. That first dose causes a flu-like symptom. We almost never see it after that. It's sort of an immune. Zometa can have a favorable effect on the immune system, and sometimes it can be like that. Claritin Tylenol can be helpful. So tough it out after the first dose, you'll be surprised. You usually don't have problems. Sometimes with both of these drugs, when you block the osteoclast, there's a rare side effect called osteonecrosis of the jaw. And that's because our teeth, we're always in contact with bacteria, and the bones can get a little damaged. And so sometimes those osteoclasts have to chew up the old bone. And for some people, when you block the osteoclast, that can cause a problem. This is pretty rare, thankfully, and we're much better at treating it. And so we do worry about patients who need dental procedures or who have a lot of problems with their teeth. We have to think twice about how we dose this. Sometimes with long term, we can actually get atypical fractures. But again, that's not so common. Oops. And low calcium. Sometimes if we stop the osteoclast from working, and now you're not taking in calcium, how are you going to build the bone without the calcium? So we want to make sure that you have calcium and you're taking the vitamin D. Unless you have hypercalcemia, too much calcium, then please don't take the calcium. Just a little bit about that rebound that I talked about with Xgeva. I just want everyone here to know and to be empowered, because we're all busy. Doctors are trying to worry about what's the next treatments, look at blood counts, all this stuff, that we sometimes lose track of how often patients are getting the drugs. For Xgeva, we can't go longer than 6 months. If not, you have that risk of the rebound. Like all of a sudden, you kind of withdraw from it. And so if you're someone that's only seeing your doc every 6 months, but, oh, I think I'll skip the visit, I'll wait 7 months, please don't, or get on Zometa instead. So anyway, this is a case of I'm just being aware if you're on Xgeva, you want to make sure that you're getting it regularly. Okay. Let's see, we got a little more time. New therapies. We now have bone building agents. The osteoclast inhibitors stop the destruction. The holy grail, what we all want, are agents that we can actually build the bone. And we do have some agents for osteoporosis, but they have not been tested in bone metastasis. I am one of the docs begging the drug companies to let us try this, but stay tuned. We're working on that. Okay, just a few slides of what other things we can do. I'll give you just a few slides of my research, and then we're going to open up to questions. So I've told you that we always want to treat the cancer. We then want to strengthen the bone. But what happens if, what are some other options we have? Like this is a shoulder MRI, and this patient has a tumor in the bone, and you can see that, and it hurts. And so what we can do is we can do focal radiation. I call it spot welding. They can do very general radiation. They can do what they call the stereotactic radiation. And in the last couple of years, they've shown that patients that have only a few metastases, they call them oligometastatic, where you might have one in the bone and one in the lung. Maybe we can use radiation to halt those tumors. And there's been very promising results with that. The other thing in the radiation therapy, so radiation very effective for local control. The other thing that can happen is we have these radium, like Marie Curie, that can emit radiation locally, and samarium, they are in the same periodic table as calcium. So when you inject the radium in, it goes all throughout the skeleton. And any tumors that are near where it's uptake, they will be killed. And we've had good experience with radium and samarium for bone pain. The challenge is it could also hurt the bone marrow. So we have to be judicious in who to use. What happens if you have a fracture? Well, we could do orthopedic surgeons can take the tumor out and then stabilize if need be. And this can help pain, this can help stabilize. And then more recently, we're starting to use more what they call cementoplasty. Interventional radiology can put a needle into the bone lesion. Let's say you have a bone lesion that's, I don't know if this is so this is a vertebra, and this one got smushed, and this one got smushed. They put in cement to build it up, and the cement actually sterilizes it, kills the cancer cells, and can also stabilize the bone. So this is something to also consider, especially if you have one place that's really hurting or weakening the bone. All right, what can we do? We've already talked, I've been telling you about the osteoblasts that build bone. Weight bearing really helps stimulate that. The osteoclasts destroy the bone. Bisphosphonates, Zometa and denosumab help stop that. Estrogens really help the bone, but so when we have to decrease estrogens for our breast cancer treatments, we've really got to think about what we can do for our skeletons. Weight bearing is one of them. I'll talk about that in a second, but calcium and vitamin D. Calcium is the key mineral in bone. Vitamin D gets you to put the calcium into bone. It also helps you absorb calcium from your diet. Low calcium and low vitamin D encourage those osteoclasts to destroy. So we don't want to do that. Got to make sure you're getting at least 1,000 milligrams of calcium a day. Vitamin D, I like about 800 to 2,000 international units a day. Sunlight, believe it or not, 3 times a week for 15 or 20 minutes can, just on a few areas of the body, can help with vitamin D. Weight bearing exercise. So I'm going to talk about, I really push people 20 minutes for at least 4 to 5 days a week. Walking is fantastic. Yoga, dancing, weight training, every bit counts, but we need to be in the habit of doing something every day. But you might say, how do I know if it's safe to exercise if I have bone metastases? So be proactive. Ask your oncologist. Look at your scans. Are there any bones that are at risk, right? You don't want to do something harmful, but they might, usually radiologists and oncologists can look at the x-rays and say, I think actually you'd benefit from exercise. You need them stronger versus, wait a second, that lesion in that shoulder that we saw before, we need to do something before you start lifting on that. And if the bone has lost a lot of the mineral, like we saw on that shoulder, they may refer you to an orthopedist or a radiation oncologist. Radiation will stop the cancer and strengthen it. Physical therapy may be recommended. And as I say, walking is great, but you got to ask your doc to make sure that in your hips and your spine, that everything's okay. All right. In the last minutes, I'm just going to give a couple of things that are happening in our lab. But there's so much. I'm in a kind of a worldwide network of bone metastasis researchers, and and I think things are, there's a lot on the horizon. So it's exciting. So we observed that this protein called AVB3 integrin, it's a cell surface protein. And we looked at patients who we had their primary breast cancer, and then we had a biopsy of their bone when they develop bone metastases. So in this series, we had 42 patients, but we've looked at hundreds of patients now. And depending on the type of breast cancer, the primary site doesn't have a lot of this AVB3. But when the cancer cells get in the bone, we see a lot of brown staining with this integrin beta 3. And what's interesting is one of my colleagues, Dr. Greg Lanza, and one of our graduate students, he created these, and you know how we have the ADC, antibody drug conjugate? Well, he created a little nanoparticle, this little nanoparticle that can bind to any cells that have beta 3 integrin on them. And we loaded them up. We've been loading them up with different kinds of drugs. We loaded them up with docetaxel. And for example, we have mouse models where we can induce bone metastases. And this is the knee joint of a mouse. And you can see the black hole in the bone from where the tumor was. And this tumor, it was an ER positive breast cancer, but it tended to be resistant to this drug, docetaxel, which is Taxotere. In this case, not all breast cancers are, but this particular one was resistant. And we found that if we put the docetaxel inside of that nanoparticle, we got significant decrease in bone destruction and significant decrease in tumor burden. And so, and there was, of course, no side effects, very limited side effects. And so we've been putting new drugs in that, and we're very excited by that. We recently just got this result. And one of the things we found in bone is that bone is our source of the immune system, the bone marrow. That's where our blood comes from. And a lot of times bone metastases, especially of all kinds, lung cancer, colon cancer, all the different kind of cancers that go to bone, it makes cancers a little more resistant to the immune attack. And so we've been really working, how can we do this? And we found that this protein, GNAS, it's a gene that regulates basically how tumors secrete and respond to acid. But anyway, it's an interesting protein we've been studying in the bone marrow. Oh, that's telling me to get moving. And that if we disrupt that protein, we can restore anti-tumor immunity. The mice start rejecting their primary and their metastatic tumors. So let me just show you this really cool thing. We labeled these ER-positive breast cancers. We've also done triple negative, and we're going to try for HER2 amplified, with firefly luciferase, believe it or not. And then we can put the mice in a black box, and we can see where the tumors go. And because they light up like fireflies. And so we can inject the mice to induce these tumors in the lungs and in the bones. And then we monitored the effect. And we found that the tumors barely grow when we block this protein. So now we're putting them in nanoparticles. We're doing all kinds of work, trying to see if we can get ER-positive breast cancer to respond to immune therapy. Okay. And so there's so much happening. There's drugs. We're trying to target the drugs to reach the bones, because a lot of times it's hard to get the bones to get the drugs to them. We know that bone marrow is a source of the immune system. We've got some novel ideas for immune therapy. There's so many new therapies coming out all the time and very exciting antibody drug conjugate possibilities. So the last slide is I've told you with the X that bone metastases induce significant bone destruction favoring tumor growth. If we strengthen the bones, we can decrease breast cancer growth in bone, we can decrease the destruction of bone, and really calcium, got to make sure you take calcium. If your calcium levels are not too high, make sure you're vitamin D proficient, not deficient, and really try to get weight bearing exercise. Exercise in general, even if it's not weight bearing, can stimulate the immune system, by the way. So I think even if you're recovering from surgery, you can do something. And then I really favor these osteoclast inhibitors, Zometa or Xgeva. So I want to thank, I've had many amazing colleagues, both here at WashU, MD Anderson's, Hopkins, UT Southwestern. I know Josh is from there. My lab, our patients, and our funding. Thank you so much.